Hello, everyone, and welcome to my delirium prevention protocol presentation. My name is Jessica Isaacson. I am currently a BSN RN working on my DNP through Maryville University. My chair is Dr. Ashton Lindsay, DNP. I would like to start with discussing what's the question that we're trying to answer throughout this research project. The PICO question is: in hospitalized patients greater than one night, what is the effect of noise and light reduction on CAM ICU delirium scores compared with no interventions within a 10-week period? To better answer our question and kind of dig deeper into it, we need to understand what is delirium. Delirium is defined as the acute change in mental status causing altered level of thinking exhibited by delusions and or hallucinations. Delirium is seen all across the spectrum. It typically comes in three different types: hyper, hypo, and mixed. These three categories are really important because depending on what state or what category the patient is in, depends on how they look. So if we're not aware of the type of hypodelirium, we might not be able to recognize that also as delirium. For example, hyperdelirium, hyperactivity can be characterized as a hyperactive state. These patients typically exhibit hallucinations, agitations, restlessness, aggression, even. This is more of our textbook, what most people think when they think of delirium. Hypoactive is characterized by motor retardation, slowing of speech, and patients can actually appear sedated. Delirium in these types of patients can be challenging to determine, especially because they may seem cooperative to staff. Mixed delirium is the most common when a patient exhibits both hyper and hypoactive phases, so those sort of cycle through them. It has been found that patients in the hyperactive state of delirium have a poorer prognosis when compared to other forms of delirium. Delirium background. Typically, in the inpatient setting, patients who are hospitalized have about a 19.6 to 17.6 rate of developing delirium while they're hospitalized. These rates have been found to be much higher in the critical care unit. 20 to 50% of patients hospitalized into the critical care unit have been found to have delirium. Delirium's costs can be upwards of $60,000 per patient per year. To kind of put that in perspective, that is typically what it costs to treat diabetes in a year. Um, Annually, delirium costs above $164 billion in healthcare related expenses. So we're not just thinking of the actual treatment of delirium, but everything that kind of comes and all the consequences from the patient developing delirium. Those are going to be billed back to that facility, making the cost of that patient's healthcare much, much higher. Also, a significant link has been determined between delirium and extended hospital stays, higher mortality rates, increased complication, and then, as we discussed, increased cost also. So, why do we need to improve delirium? With improving delirium, we're going to try to improve our patient outcomes. This is going to be beneficial to the patients because we're going to be able to reduce the length of stay, the amount of time that they're in the hospital. It's also going to help the facility because it's going to improve our costs and allow our resources to be better served in other areas. The proposed change for this research project was adding a new noise and light reduction policy from the time of 2030 to 0700 in the critical care unit. During this time, overhead lights will be dimmed and staff will make a conscious effort to reduce noise through adjusting alarms appropriately and limiting interruptions. The goal overall of this new policy was to reduce the current delirium rates by 10%. The goal sample size that was determined was about 154 patients we really wanted to examine to help get a wide range of what our delirium rates typically look like. Research to support change. There is a very well-known approach to delirium prevention. It's called the ABCDEF delirium approach. It uses awakening, breathing coordination, delirium monitoring, early exercise, and family involvement. This focuses on the critical components, all of these combined together to reduce delirium. This bundle serves several features, as discussed. Many studies support these interventions as successful in preventing delirium by up to 50%. On average, patients breathe independently for 3 more days compared to those in the controlled study. The question now becomes, how can we better incorporate these prevention strategies into the daily routine of a busy ICU? This project intends to set common nursing goals in the ICU to help improve the implementation of this. The tricky part with all of the research that supports this is all of them used a bundle as a whole. They were not necessarily looking at specific parts. So we don't know if maybe waking the patients up, that A might be much more effective than D, delirium monitoring. So that's why this project decided to break it down into simply noise and light reduction, focusing on those two components to determine if that is helpful in reducing delirium. The project setting. The project setting will take place in a 16-bed ICU located in rural North Dakota. The facility is Alter Health Systems. Roughly, the facility has about 262 beds. Important considerations to consider when looking at any location include the socioeconomical impact. There was not a lot of ethnical diversity within the sample size, and then the ICU was mixed medical and surgical patients. So just some important things to consider when we're looking at the results of the study. So this project was broken down into a total of 6 steps, and those are all laid out here. Step 1 included educating the bedside staff within the ICU, just so they were aware of the project, they understood what we were doing. We already, within the unit, monitor delirium twice a shift, so that part wasn't anything new necessarily, but just kind of reinforcing that it's important that we don't forget those. So just educating, talking about the staff, making them aware of the project. The next step is actually implementing that noise and light reduction policy, telling them starting on this day, we're going to be shutting off the lights, we're going to keep a schedule, we're going to make a conscious effort to reduce noise, and picking a date for that actual implementation. The next step was collecting the data. So once we implemented it, we collected the data for about 10 weeks. The next step was we had to send a referral form to our research department within the facility requesting specific data from those dates. Step 5, in order to get our pre and post implementation, we took 10 weeks prior to that date of implementation, looked at the data and the rates of delirium, and then we did the 10 weeks following. So we had a total of 20 weeks of data that we gathered. And the final step, of course, was to examine that data, analyze it, and look for the puzzle pieces to kind of put together. Was this effective? Did we actually make a difference within these patients? So the data collection tool, what we typically use in our ICU and is well used throughout many ICUs across the country, is called the CAM ICU assessment method. This was started from Vanderbilt University. It is not copyrighted, so a lot of hospitals use it. It focuses on 4 main components in determining if delirium is present. These include altered mental status, inattention, altered level of consciousness, and disorganized thinking. I attached a nice little flow chart as a reference to kind of understand how it walks you through Our CAM ICU score is actually built into our Epic system, so that's very nice. So as you click through, it asks like, does the patient have altered mental status? Yes. Then it goes on to the next one. Are they inattention? No. No delirium. So it kind of steps it down so the nurse isn't trying to follow the whole flow sheet per se. But they definitely are still understanding what it is and what it's monitoring for. Things to consider when you're completing this method: if the patient is, for example, sedated, or maybe they have a breathing tube and maybe they're paralyzed, we have a lot of different things that we have to do for our patients, and then they cannot communicate with us. So when that happens, we can't necessarily assess if they really are delirious or not because we may have had them asleep for a week or two. So we can only expect at the point that they wake up, they will most likely be delirious. But during that state and during that time of unawareness, you could say, we really can't monitor whether or not they're delirious. So at the end of the assessment, the tool will generate a yes or a no, and that is yes, delirium is present, or no, delirium is not. And that is what we looked at when we looked at the rates of delirium. We essentially looked at how many times the tool generated a yes in that pre-implementation of the policy, then how many times it generated a yes after the noise and light reduction policy were implemented. Okay, patient sample criteria. We had to specifically look at what patients could be included in the study. One of the big factors was even simply age, just because patients under the age of 18 are considered minors. You need additional training, additional consents, as well as those over the age of 89. So those 90-year-olds and above can be another class that's a little more harder to do any type of research on. Another thing that was important is that we really wanted to be looking at patients who were admitted into the ICU for at least 24 hours. If they just came back there for 6 hours or 12 hours for some quick monitoring, that doesn't really give us a good ability to determine if they're delirious or for them to even truly develop delirium if you're only in the hospital for that short amount of time. Other things to consider was underlying diagnosis. If somebody already has dementia or they already have a cognitive disease, that makes it much more difficult to determine if it's actually worse while they're in the ICU. Another part that we did exclude was also our COVID patients, just because the level of care they required, as well as most of our COVID patients during the time of the study were separated into a separate 8-bed ICU that was not included at all. So our final results: when we looked at the 10 weeks prior to implementing the noise and light reduction policy, we found a total of 28 patients out of 333 had positive CAM delirium scores. This makes our pre-implementation group delirium rate of approximately 8.41%. So still well below that of other facilities, but still pretty significant. 1 in 10 patients was developing delirium. Post-implementation, so after we implemented the noise and light reduction policy, we only had a total of 9 out of about 278 patients that were found to have positive delirium scores. So the post group rate was about 2.23%. So when you look at these two percentage, we had a very significant drop. The overall drop from the pre-implementation group to the post-implementation group was about 38.41%. This impressively surpassed the goal of a 10% reduction. Further analyzing the data, a z-test of 2 proportions was performed to determine if the statistical analysis was at a significant level. The p-value was found to be 0.0038, which is significantly less than the standard of 0.05. This just strengthens our study, strengthens that the results were in fact correct. The achieved power of the study was 0.85 to 76%, which is considered very, very strong. So we had significant evidence to show a change in one direction by reduction. So when we look at all of these, we determine that the null hypothesis is in fact rejected, which is a positive thing. Data interpretation. Again, we just found strong correlation of noise and light reduction to reduce the delirium rates in the critical care setting. The observed outcomes far exceeded the expected delirium reduction rate of 10%. When considering the consequences of any study, the results need to be correctly interpreted. This study removed patients currently requiring mechanical ventilation due to medications needed to obtain the mechanical ventilation. These medications have significant sedation effects and can alter mental status. So these patients, as I previously talked about, they were not included in this sample size. Strengths of the study. The goal reduction was of 10%, and we far exceeded that by 38%. That is so wonderful. The goal sample size was 154. Our actual sample size ended up being about 611. So that was about almost 4 times what our goal was. So that, again, just helps strengthen the results of our study. And that was after we looked at our inclusion and exclusion criteria. So the gaps or limitations that were found throughout the study was, as I talked about, the research to help support the study used multiple interventions when looking at delirium prevention, and we really wanted to just focus on the noise and light reduction. Using that CAM ICU method, some patients were not able to complete it on. It would have been really interesting to see. I didn't have the ability to follow up with patients, after they were intubated necessarily, or to look at those intubated for longer periods of times and the rates of delirium that they experienced. And then, of course, the exclusion criteria also has to be considered something. We weren't able to take everybody into consideration for the sample size. Some barriers to success that were determined was, of course, staffing. I think anytime you're in the inpatient setting, staffing can be challenging, but there were a couple times when the lights were not dimmed at the appropriate time at that 20:30 at night, just because staff were covering more than what more than what the expected patient ratio was. So people simply just lost track of time, got too busy. They were providing patient care, which is, of course, our number one priority. The next barrier was that these are critical care patients, so they're requiring a very high level of acuity. So this comes with frequent interruptions, alarms, lots of machines. The next barrier was shared patient rooms. We do have about, I think it's about 8 patient rooms within the ICU that are shared. So they're not completely private, they're partially private with a curtain. So if you have a neighbor that is on a ventilator and they're alarming a lot, or maybe they're just critically ill, that's most likely going to keep the other patient up who might be in for a lower level of acuity. So overall, when we look at those few nights that the lights were not shut off at the appropriate time, we found that the new policy compliance was about 94%, which is still very, very good. So continuing on for future practice, implementing the noise and light reduction policy into other departments within this same facility would really be an important goal and important thing to do. We implemented it within the ICU, but these could definitely be implemented on other floors of the hospital. They most likely have a lower rate of delirium just because they do have private rooms. They don't have as many alarms in the room. They don't have quite as much monitors. But patients, anytime you're in a facility spending the night, the chances of you being interrupted or losing sleep is there. So we need to still be monitoring for delirium for all these patients. So the goal would to be implement the new policy hospital-wide, and then to continue to monitor for delirium and see what our rates of delirium were over the whole hospital. So looking at that 262 beds all of them. Once we have that data, then we can really encourage other facilities to also implement noise and light reduction and kind of see the importance of reducing delirium. This project was fairly sustainable just because it didn't really require any additional staff or any additional equipment. So it was very cost effective, which was nice. Um, it could be an easy hospital-wide policy. I know our hospital announces when the visitors need to leave, and that takes place at a set time every night. So if when that announcement comes through, if we can shut off the lights, that would be great. And then, of course, to just continue to monitor the delirium so we can see where we're at and how we're helping our patients improve. And then I also attached all of the references for your convenience. Thank you so much.